Hello, and welcome to today's episode of A Cancer Conversation with the Georgia Cancer Center at the Medical College of Georgia at Augusta University. My name is Chris Curry, and I am the host for this podcast series. I work at the Georgia Cancer Center as the Communications and Marketing Manager. In today's conversation, we're going to cover a series of topics related to breast cancer. As many of you probably know, October is Breast Cancer Awareness Month. And so we have a couple of experts joining us for this conversation. First, Dr. Alicia Arnold. Dr. Arnold is a breast surgical oncologist here at the Cancer Center and Augusta University Health. Dr. Arnold, thank you for joining me today.
Thank you for having me.
Well, we are honored to have you. I want to start off talking about you and your passion for working with breast cancer patients. I know you've been here a while, and that's something that I've always seen in working with you and talking to you and seeing you interact with your patients. What made you decide that this was the right opportunity for you?
Well, I've actually been here 5 years now, and it's been such a great opportunity here because there was so much potential at this cancer center, and they really needed a little oomph to their breast cancer program. So I was very happy to come in and fill that role. I wanted to be a doctor, I wanted to be a surgeon, and as I was nearing the end of my medical school training, I actually was unfortunately diagnosed with breast cancer, which is just not the typical pathway you expect to take when you're about to finish medical school, which was heartbreaking to take a leave of absence, stop my studies, and of course I had to undergo treatment for breast cancer, so I underwent a lumpectomy. I had what's called an axillary dissection where they remove all the lymph nodes. I did chemotherapy, which of course lost my hair.
Yes.
Did radiation, and then completed another year of a medication called Herceptin. And so it was a struggle for sure, but once I actually came back to my rotations, I was paired unknowingly with a breast cancer surgeon, and I thought, breast cancer is the last thing I want to see or do. And to be honest, it was so different because I was actually very comfortable. I felt that those patients who were really scared and anxious about the next steps, I could actually step in and say, hey, is it okay if I talk to this patient? I just finished this treatment. This is what a chemo port looks like, things like that. And it really it made me feel more comfortable. I'm always going to be extremely passionate about this field because I've been through it. I just hit my 13-year survivor mark, which is huge.
Congratulations.
And so thank you. And, it has allowed me to connect with my patients on so many levels. And so every single day I'm doing it for them and myself. And so I love what I do, and I love helping all these wonderful women.
I know that we interviewed Dr. Lauren Bigham a few episodes ago, and we talked about mental health and emotional health. What does it mean to these women to learn? Because I know it's not something that you always share openly because you want to focus on the patient and their care and their needs. But what is it like when they hear that you're also a breast cancer survivor?
You see a change in their face, and they kind of relax because I think they realize that, it's scary being a patient and not knowing the next steps. And you just worry, is this the right physician for me? Is this the right treatment? Should I be doing this or that? And they're so nervous that when you hear, hey, not only am I your surgeon, but I'm also a survivor and have been through all of these steps, it just changes everything. They clearly trust me. I think that's the biggest thing. They confide in me. They ask me questions. What was it like for you? Did you have these similar symptoms afterwards or side effects? Things like that. And as you mentioned, I really try not to, the reason I'm very open about my being a breast cancer survivor, but at the same time, I don't want to be like, I've been through it. Your journey is just like mine, because it's not. Yeah. So I do, a lot of them know ahead of time. They've maybe read about me and looked me up. And so they say, I heard you went through it. Can you tell me about it? And just as a patient myself, I found it to be so relaxing and comforting to talk to another survivor. not necessarily my doctor, that would have been great, but meeting other survivors, because they look normal. You can tell they feel good and they've been through it. So I think that helps me, it helps them. And then we just form a bond, if more than anything.
And talk to me about how strongly you feel about taking care of not only the patient's physical cancer, but also their emotional and mental health. I mean, we talked about that with Dr. Bigham, but I also know that you're a big proponent of that.
Yeah, it's extremely frustrating that a lot of insurance, even private insurance, does not cover, or they cover a very small portion of mental health coverage. Now, we're talking about people who may not have any mental health problems. They've never had anxiety or depression, but now you just give them this diagnosis of cancer and their whole world comes crashing down. And it's not necessarily that automatically we think they're going to have mental health issues. It's just that that's a lot to take on. And the physical changes that they're going to go through, losing your hair, maybe losing your breast, just the way you feel after chemotherapy and surgery, it can be so mentally taxing that we feel so strongly that is a part of the treatment plan, that they should be able to see a specialist who treats people going through cancer as a therapist, just to kind of allow you to give some coping mechanisms. How am I going to get through this? And so one big thing that we pushed for was Unite in the Fight. We did the walk, and those funds that you all come to these walks and raise money for go directly to the patients. And so I took that as an opportunity to apply for funds for mental health coverage for breast cancer patients if it wasn't covered. And I was awarded those funds. It's still going, which is amazing and has helped so many people. So I think that, we know that women will do better if mentally they're in the right place.
Yeah.
So I think that comes 100% with the other treatments we're giving them as well.
Yeah. Of course, we will be talking about Unite in the Fight Against Cancer and what that event will look like in 2023, hopefully in the coming months as we get some planning underway. So you talked about losing your breast as a possible option. You had a lumpectomy as your surgical treatment for your kind of breast cancer. Let's talk about the different types of surgical options when it comes to treating breast cancer.
Absolutely. So the two most common are a lumpectomy, where you're removing the tumor and some tissue around it, or a mastectomy, where we remove the entire breast. Now, one thing to clear up is that, mastectomy, there's what we call skin sparing, nipple sparing, or simple mastectomy. And it totally depends on if the patient's going to also get reconstruction at that time. So if they're going to get reconstruction, they may have nipple sparing, skin sparing, where we leave extra skin or even the entire skin envelope with the nipple and areola, as opposed to a lumpectomy, which is just a small portion of removing the breast.
Okay. And next, how important is it for patients? Obviously, there's a lot that can go into preparing for surgery and understanding it. How important is it for your patients to make sure that they understand the surgery process and all of the details involved?
Absolutely. So we're going to have to make an incision. There will be a scar. I do pride myself in the cosmetics of the operation and try to put the scar somewhere that hides very nicely. There's most of the times, if we do a lumpectomy, the patient can expect to go home the same day. They do not need to stay in the hospital overnight. If we do a mastectomy, we usually just keep them overnight, so maybe less than 24 hours, just to monitor for any bleeding and make sure they can manage a drain that would be placed. So when we do a mastectomy, we will have a temporary drain in place. Very different surgeries. Mastectomy is a longer recovery. It's just we're taking a lot of tissue. We're taking it off the chest wall muscle, which can be pretty painful. And so they might have some restrictions with mobility, just temporary. And then, for a lumpectomy, they might have some swelling. a little discomfort, not usually to the point where they have to take anything stronger than Tylenol or Motrin after that. So they're quite different. And, we do try to push for a lumpectomy for a breast cancer treatment surgery more so than mastectomy. We really don't want to push for that surgery unless it's absolutely necessary.
Why is that?
So one thing is just the recovery. It's a big surgery. It's not as simple as people think. I hear people say, well, if it were me, I would just have both breasts removed and get new boobs. And that's how they phrase it. And I wish it were that simple. It's really, there's so much more into that, more that goes into it. And we wish we could make everyone look like a supermodel after having their breasts removed. And unfortunately, there are many patients where we can't. And so I do want them to understand that it's, there can be some challenges with their surgery or the cosmetic portion of it, where that can be emotionally and mentally scarring as well as the physical scars. So it's a drastic change in their body, whereas a lumpectomy is not. One of the other differences too is the survival's the same. So it's not that people do think that mastectomy is superior to lumpectomy. Well, if you have both breasts removed, you're cancer free. You never have to worry about breast cancer again. As we all know, many women have died from breast cancer who've had both breasts removed. It's just an unfortunate situation. It depends on the type of cancer, lymph node involvement, if they have any genetic predisposition. So we need to understand that the mastectomy alone versus lumpectomy with radiation, survival's the same, and patients will do just as well. I have women that have a lot of medical problems, and putting them under anesthesia for a couple more hours as opposed to about an hour for a lumpectomy, for what reason? What benefit? If I'm not giving them any benefit by doing the mastectomy, lumpectomy is the safest.
Okay. In past episodes, we have talked about our nurse navigator program and the role that the nurse navigators play in guiding patients through their cancer treatment process. What role do the nurse navigators play? How important are they in your treatment team in the breast cancer care program?
They are pivotal. So the nurse navigator comes on scene at the moment of diagnosis. She is the point of contact for that patient. She helps guide them through this entire journey from the time of diagnosis through their last treatment and then even in their follow-ups. She is the person, and I keep saying she because my nurse navigator is a female, but she is the person that, if they have any concerns, questions, they call her. Mm-hmm. And she is along that journey for them. She's the liaison between medical oncology and surgical oncology, meaning as the patient transitions from both, she's still that focal point of contact, and she's a part of that patient's treatment plan. And so we truly utilize the navigators to navigate this entire process for the patient. We want it to be easy. We know that they get a lot of information at once. It is extremely overwhelming. It's very common that after I tell a patient they have breast cancer, they do not remember anything else I say after.
Yeah, I can imagine.
And my nurse navigator specifically knows my plan, knows, and she always meets with the patient the day they meet with me. And then they call her and say, I don't remember a thing she said. Can you go over that? Mm-hmm. So we really do rely on our navigators to, help the patient through this entire process in every step of the way. And so sometimes it might be, I don't know when my next appointment is. She's going to have the answer for him. Or, hey, I feel a lump or I feel something different since my surgery or since my last treatment. Can I have this looked at? And we go from there.
Okay. All right. Now, in doing research and in talking to you about this episode before we sat down to discuss, I know there were some myths about mastectomy that you said you wanted to clear up. Talk about those.
Well, I did touch on that a little bit ago when we mentioned lumpectomy versus mastectomy. So I just want every woman to know that a mastectomy is just not 100%. Meaning, even after you do have a mastectomy, there is still about a 3 to 4% chance it can come back, even in that chest wall, even if no tissue there is left. So it's a little disheartening to hear that. But I think that when I hear patients say, that so-and-so had a mastectomy and that's what I want because I don't want it to ever come back. And I have to tell them, I hate to tell you this, but there is always a chance it can come back. Cancer is an ugly thing. Mm-hmm. And it takes one abnormal microscopic cell. It doesn't take a whole breast to create a breast cancer. So we have to educate the community that a mastectomy itself is just not curative. And it is in the sense of surgery and removing the tumor. Mm-hmm. Got it. But 100% never going to come back is just not the case. So I don't want people to think also because they've had it in one breast that they have to have the other breast removed. That's also a myth. And, often after a woman's completed all of her treatments, her risk of getting breast cancer in the other breast is pretty much back to the normal average.
Okay.
The only caveat, and I will say this, is that women who have a genetic mutation, like BRCA1 or 2, mm-hmm. there's a whole host of more. Remember that too. There's not just 2 genes. Now there's a lot more. Those patients do have a higher chance of it developing in the other breast. So in those patients, we do recommend removing the other breast. And then as well as, like I said, the survival is the same, so it's not superior to the other. And just that it is, the cosmetic portion of it, it can be a long process. The breast will never look exactly like your original breast. And I think that's something else I wanted to clear up, is that the thought of just, it's like as if we're just popping in implants.
Yeah.
And I wish it was that simple. It's just not. And so we have to work with every patient is extremely individualized with their treatment, their surgery plan. And so we have to do, ultimately, we're here to cure your cancer. And then secondly, we want you to look good and feel good. And if there's anybody that takes that to heart more than anyone, it's myself. And I really take time, in the operating room, making sure everything looks beautiful. We also got to do what's safe, and it just is important to kind of keep those aspects of the surgery reasonable and realistic expectations.
I have a question for you,
Sure.
if you know the answer. This is not planned. This is just something I thought of.
Okay.
So you said 3 to 4%, the cancer can still come back even if you have a mastectomy. Mm-hmm. What if you have a mastectomy, but you have that reconstruction that you talk about? Does adding, however you reconstruct, rebuild a breast, does that increase that 3 to 4%? Or is it still just 3 to 4%?
Still 3 to 4% overall. It happens to depend on, the removing as much breast tissue as you can possibly see. Breast tissue is yellow, fat is yellow. It's a difficult line to draw in the sand of exactly that you've removed every single bit of breast tissue. Mm-hmm. So patients who could have a higher chance if they have like a little bit more residual breast tissue. But no, the reconstruction doesn't change the recurrence. It could possibly, depending on the type, maybe limit picking up a recurrence, if that makes sense. That just depends. Not to say that you should definitely do the reconstruction, but if it's an implant that's on top of the muscle, that could be a little difficult to feel if there was a tumor on the muscle, if that makes sense. And then I do want to say that for a lumpectomy with radiation, the recurrence rate's about 4 to 5%. So that's the difference.
Okay.
Barely.
Okay, gotcha. Okay.
And that's just recurrence. Survival is still the same. So even if it did come back, I've had patients where it did come back, sometimes 20 years later in that same breast, we still found it at an early stage. It was still cured, and they're doing great. So
yeah. Let's talk about finding it at an early stage. So mammograms, we always talk about mammograms during October, but mammograms are important every month of every year.
Yes. Mm-hmm.
So
yeah, October's Breast Cancer Awareness Month. I say this all the time, but every month is Breast Cancer Awareness Month
Yes.
because you should check your breast and be generally familiar with them and notice if there's anything that comes up that is of concern that you bring it to a physician. It may not mean that you end up getting a big fancy workup and a surgery or a biopsy. It may be something very simple. But mammograms do pick up things. If we, on exam, we're going to usually find something maybe when it's a centimeter or more, right? Not always. Mammogram's going to pick it up when it's this big, when it's tiny and not even felt on exam by the patient or myself. Mm-hmm. So that's why we call it a screening, because it will just screen both breasts, looking for any abnormalities that weren't there before, need to be worked up. And a lot of breast cancers, when they're caught on mammogram, they're caught at such an early stage that the treatment algorithm is totally different, and it can be very brief. Mm-hmm. It can be a very short treatment. You just have a lumpectomy. You may or may not even need radiation. You may not need chemo. I mean, a lot of patients don't need chemo. So there's a huge benefit of finding it sooner rather than waiting until it's about this big.
Yes.
And then going to your doctor.
Yes. And when can women start getting mammograms?
So right now, there is the option of starting at age 40.
Okay.
But age 45, you should be getting a mammogram every year.
Okay. Mm-hmm. Men can get breast cancer too. We always talk about that as well. Mm-hmm. But it's much lower, right?
Right.
The rate?
Much lower. So there's not there's a handful, few thousand cases a year. However, doesn't mean men should be getting mammograms or anything. One thing I like to point out is that almost always, if a male develops breast cancer, it's a nodule directly behind the nipple and areola. And that's important because that's an easy thing to check. Mm-hmm. Just feel that area and see if you've noticed any nodules or anything. But, sometimes if a man feels something kind of way out on the chest, it's less likely to be a breast cancer.
Okay.
It could be something else, but I mean, that's typically the most common location. So if you are going to check just around the nipple areola, that's where it happens.
Okay. Going back to the different types of surgery, talk about side effects and anything patients can do to reduce those side effects.
So the surgery itself, the side effects, just, discomfort and pain after surgery are not as severe as people might anticipate. We do want you getting up and moving around after surgery. Nobody's going to be bedridden. And there can be some discomfort, but a lot of it's temporary. So over time, just like healing from most surgeries, they should feel a lot better. One thing that is pretty common in my lumpectomy patients is that, there's this scar tissue, kind of like a web of scar tissue that may form in the breast. And as a woman has hormonal changes, that breast tissue swells and it kind of hits that scar, that web of tissue, and the breast tissue can't really swell. Well, it hits that and causes aching pain. And my patients freak out. It's been 6 months since my surgery and I just got this stabbing pain in my breast. And I explain it to them perfectly because I know exactly what they're talking about. I was like, did it just happen out of nowhere? And they're like, yes. And it feels like a hot poker, like it just comes out of nowhere. It zings across the breast. It can be alarming. And, our breast tissue is different from other parts of our body because it responds to hormonal changes. Even if you're menopausal, you still have some hormones in your system. And so we just have to be aware of that random sharp shooting pain can come out of nowhere. As long as it subsides and goes away, it's not constant, then you shouldn't need to worry about it. As far as mastectomies, obviously a much bigger surgery. Even if we can keep all of the skin, nipple, areola, put in implants, and they may look fantastic, there is a chance that they will not fully recover sensation to the skin. So even though we can mainly do this for cosmetic reasons to build that breast and make it look as great as it does, just be aware that there is some sensation deficits from those surgeries as well.
Okay. Talk about lymphedema, because I know that breast cancer surgery, you talked about removing lymph nodes that can also cause lymphedema. Talk a little bit about that.
Yeah, so one thing for everyone to know is that the more lymph nodes we remove, the higher the chance of lymphedema. So if you've only had 3-4 lymph nodes taken out from the armpit area is what we're referring to, then your chance of getting lymphedema is extremely low. If you have 20 or more lymph nodes removed, if they were positive from the cancer spread, your chances is much higher, more like 20 to 25%. And that's lifetime, meaning you may not have lymphedema right after surgery. Could it develop in a year or two? Absolutely. Of course, if we throw on things like radiation, that can also worsen that and cause it. So what we have done here is created a lymphedema prevention program. So we have our patients get education prior to surgery with our lymphedema specialist, Hari Kashyap, and discuss what to expect, because there's a lot of it's an on-table decision. I'm in the operating room, the lymph node tests positive, I'm going to remove all the lymph nodes. Patient wakes up with a drain. And we want to make sure they're educated on exactly what to expect before all that happens. So after the surgery, let's say they don't have any lymphedema, and that's just kind of this diffuse arm swelling that can happen. We still do, we have a very high-tech machine that measures basically body water changes in one arm compared to the other.
Okay.
And it will notify us if there's any abnormal changes before we see it. So that's the beauty of it, is that the patient may look totally normal, get on there, and they get an abnormal score, and we check about every 6 months.
Okay.
So if in 6 months it's starting to go up or things like that, we can actually get them back in with our lymphedema specialist. He can do different exercises, compression garments, etc., and prevent the lymphedema from ever occurring.
Okay.
So that's our goal. It's something we educate our patients on, but it's a nasty side effect we hope doesn't happen.
Yeah. I would be remiss if I did not talk about the breast cancer community survivor social, because I know that's another passion project of yours. Talk a little bit about that and how it can help breast cancer survivors.
Absolutely. So we are currently meeting every fourth Monday at 5:30 p.m. at the Imbert Story Research Building on the first floor, and it's at 5:30 to 6:30 usually. We do have some food and coffee and drinks. And just to be honest, as a patient, when I sat down with other patients going through what I went through, or sat down next to someone who finished treatment 15 years ago, and I was in my 3rd month of treatment, it was life-changing. And I felt that we didn't have a support group or social group set up at the time when I came here, not one that was regularly attended. So I wanted to revamp that because I felt it's so crucial. And it's amazing the number of patients I have where their stories are so similar. Mm-hmm. And I'm like, man, if she just knew this one and they connected, this person would be doing so much better and could relax a little. And so it's been successful. We did develop a little bit of a hybrid program where it's virtual and in person because of COVID. And so now, but I think it's great anyway. I have patients who might live 3 hours away and they just can't come, or they're on active chemo and don't want to be around other people. But so it gives them an option to attend even if they're not physically in person. So we are meeting now. I mean, it's just been so impactful, like those connections being made, volunteering, research ideas, collaborations on different projects, just things that people say, I never knew about that. I didn't know that. I thought I was the only one that went through that. I just realized everybody in this room went through the same thing. Yeah. And we try to have a speaker every month of a different topic. So, we've had medical oncology, myself, surgery, radiation, psycho-oncology, radiology, et cetera, all of those. And then last month we had a recent survivor. And this month for October, we have a very wonderful, astounding patient of mine who's going to share her story. So it's great to be in a place where you can get additional information that's not just Googled on the internet, and you're actually getting factual information that can be beneficial in just their healing process. So
good. Well, Dr. Arnold, thank you for taking the time today to be part of this conversation. Sure. I always enjoy talking to you and hearing from you, because I know that you have so much information to offer our patients and those watching, listening to this podcast episode. Now, after the break, we will be back with Dr. Jordan Ciuro. Dr. Ciuro, of course, our newest member of the Breast Cancer Care Program, to talk about genetic testing and other preventative steps, and also different chemotherapies available for breast cancer. So we'll see y'all in just a minute. And we are back here at the Georgia Cancer Center at the Medical College of Georgia at Augusta University. We are continuing our conversation about breast cancer. October is Breast Cancer Awareness Month, and we are proud to have a team dedicated to treatment and care for both women and men being treated for breast cancer. Joining me now is Dr. Jordan Ciuro. Mm-hmm. Dr. Ciuro is a breast medical oncologist here at the Georgia Cancer Center and Augusta University Health. Dr. Ciuro, thank you for taking the time to be part of today's conversation.
Well, thank you so much for having me. I'm excited to be here.
Well, we are excited to have you here. Now, you are actually one of the newer members of the Georgia Cancer Center family team. What brought you here?
Yep, so you're absolutely correct. I recently joined in July, so a few months ago.
Okay.
It's crazy to think I've already been here for a couple months. Time has flown by. What brought me here is, I actually am Canadian, and I did a lot of my training in Detroit, Michigan. And once I graduated, I really was looking for an institution that really focused on academics. And the reason for that is because I really value just superior patient care for my patients. I was looking for an institution that was giving cutting edge treatment options, amazing resources such as clinical trials. And so that was, pretty much the number one aspect I was looking at in an institution. And upon interviewing, I really fell in love with the Georgia Cancer Center. It really reminded me of home in Detroit, Michigan. Everyone here was just extremely welcoming. Just the leadership alone with Dr. Cortez, Dr. Jalala, they're leaders in their field of medicine. So it was just amazing to interact with them and have them as potential mentors. And plus, being at an academic institution here, it allowed me to pursue my passion for breast cancer. I don't know if you know this, but I also do, on Fridays, I treat genital urinary cancers, and there was an opening for me to do that as well.
Okay.
So it was just a perfect mix of having that academic portion with superior patient care in a location with great mentorship and an area where I can basically excel and really give superior care to my patients.
And why did you decide, why breast cancer? Why was that sort of your passion during your medical school training, your residency, et cetera?
Yep. So it actually took a bit for me to figure out what field of cancer I really wanted to devote my time to. How it works in medical school and in residency is you spend various months in different, subspecialty clinics. And I realized quickly that I really was passionate about all fields of cancer. But it wasn't until my breast clinic month where I realized that I really cared for this patient population. And they are just a very vulnerable patient population, and it really is a journey throughout their breast cancer treatment. And I even found myself, actually on my days off, going back to the breast cancer clinic and spending just all my time there to be with these patients throughout their journey. So that alone was kind of, a light bulb for me of, okay, this is it. I want to spend my time and really help this patient population. So I think it was more so the emotional aspect, but also just the clinical field, the advancements in breast cancer. I was joking with my friend the other day that, I keep up to date with, journal articles weekly, and every week there's a new drug or clinical trial available for our breast cancer patients. So I think it's just such an exciting field. We just have so much to offer them. And so it's a very exciting time.
Can you talk about some of the advancements that you've seen? It sounds like you keep up to date on the journal information. Can you talk about maybe one or two of the biggest advancements that you've seen
Of course.
sort of during your time?
Yep. So when you look back in like old textbooks, when you treat a breast cancer patient, normally you have to determine if they're localized or metastatic, meaning outside of the breast. And if there's a patient with a breast cancer that's localized, ideally back in the day they would remove the breast and follow up their treatment with toxic chemotherapy. But now, just with our advancements, we're realizing that there's so many different targeted drugs. We have targeted drugs specific to a HER2 receptor, which makes up one of the 3 most common breast cancer subtypes. And that alone is just so specific to that type of breast cancer tumor with minimal toxicities. And we're actually seeing these patients live many, many years with minimal side effects. So just our HER2 breast cancer field is just growing significantly. We're also seeing a role of antibody drug conjugates, which is this like new type of concept where we are actually able to, connect chemotherapy to an antibody, and that antibody is directed specifically to the tumor. So instead of giving someone, chemotherapy, which technically will kill anything that is rapidly dividing, these antibody drug conjugates are actually almost guiding the chemotherapy specifically to the tumor, decreasing side effects, and just really having fantastic results. So
that sounds awesome.
It's very exciting. Yeah.
Good. All right. So before we interviewed Dr. Alicia Arnold, who is a breast surgical oncologist. Now we're interviewing you. You're a breast medical oncologist. Talk about sort of the differences between those two roles.
Sure. So it's a great point that you're stating, because there is a difference, but despite there being a difference between a surgical oncologist and a medical oncologist, we really do make up a team, and we have the goal of superior patient care. We meet weekly to really discuss our patients in detail, where we review their their imaging, their biopsies, pathology reports, to really come up with a plan together. Our roles are different, and I do have to say that Dr. Arnold and also our other breast surgeon, Dr. Aurora, both fantastic colleagues. I've been so impressed by the way they undergo their their surgeries, and my patients just speak so highly of them. So it's been a pleasure to work with both of them. But the roles are different, because when you have a breast surgeon, for the majority of times, they actually see a breast cancer patient at the time of diagnosis, so more so earlier breast cancer. Usually the patient will have, an abnormal mammogram, or will palpate a mass. That leads to imaging, a biopsy, and after confirming, a diagnosis of cancer, Dr. Arnold, for instance, would evaluate the patient to see if there's a role to remove either part of the breast, so a lumpectomy, or their whole breast, meaning a mastectomy, to try to remove the cancer. And then they also do play a role in managing, reconstruction after the surgery. But my role as a medical oncologist is quite different. So I actually see a patient at different times during their care. So I can come into play at the very beginning of their diagnosis, where I would communicate with Dr. Arnold and see if there's a role of giving systemic therapy, either chemotherapy, targeted therapy, or anti-hormone therapy prior to surgery, with the goal of trying to decrease the tumor size to allow better surgical outcomes. There's also a role for a medical oncologist after surgery. So after surgery, let's say, the pathology report shows that the tumor is actually quite aggressive. We would perhaps want to add more therapy at that point in time with chemotherapy or anti-hormone therapy. So we really, communicate with our surgeons to determine the best role of systemic therapy when it relates to surgical outcomes. And then different from a surgical oncologist is I would see a patient when they're diagnosed in the metastatic setting, meaning, their breast tumor has now left their breast, perhaps even left their draining lymph nodes, and have gone to perhaps their liver, their bones, where there really isn't an option to surgically resect all of these various, foci of cancer. And at that point in time, my role would be to give them systemic therapy to really try to control the cancer growth while decreasing side effects and improving survival. So very different roles, but at the end of the day, we're a part of a team, and we really have the same goal of just helping out our patients.
Let's talk about that team, because we've done previous episodes where we have talked about our tumor boards and how it really is a multidisciplinary team approach. But some of those people have been part of that team for a number of years because they've been here a number of years. But you, being here since July, what has that team experience been like for you in helping to determine not only the best care or plan for your patients, but also Dr. Arnold's patients and your other colleagues?
So it's been fantastic working with the team here. Not only, it's been a great experience working with the surgeons, but even just the medical staff. Our nurse navigators. We wouldn't be able to do our job without our nursing staff. Our front desk. Just everyone really helps our patients. Just really manage their care, because it's one thing for me to provide treatment to my patients, but after the patient leaves the clinic, it really is the nurse navigator who is calling the patient, making sure they follow up with their appointments. So I feel like it's been a great experience. I can't speak more highly of everyone I've met here, and it's made my transition here just extremely easy and great, actually.
Well, good. That's awesome to hear. I'm sure they would. I'm sure they would love to hear that. So hopefully they watch and listen. So let's talk a little bit about genetic testing, because I know that there have been a lot of conversations, a lot of discussions over the past probably decade to 15 years or so about genetic testing with breast cancer, BRCA1, BRCA2. Talk about what options are available for those concerned about their genetic risk of developing breast cancer.
Yeah. So that's actually a very hot topic now in the field. I think the field of not only breast cancer, but many other cancer types, we're really moving towards genetics and molecular mutations. And I think, it's just very important for patients to understand that there are mutations that can be present specific to them. You did mention BRCA1 and 2, which are the most common, breast cancer mutations. And it's important for us to not only, be able to identify high-risk breast cancer patients who might actually benefit from undergoing genetic testing, but it's also important for the patient, because if they do have this rare, or not even so rare, maybe about 5 to 10% can have this genetic mutation, it's important that they also are aware of this, because if they have sons or daughters, they are actually at risk of developing not only early breast cancer, but these genetic mutations are actually linked to an increased risk of like pancreatic cancer, ovarian cancer, melanoma. So it's just important for us to be aware that they exist. We have to be able to identify who is high risk and who would benefit from undergoing genetic testing, because it not only provides us a line of therapy we could offer them down the line, but we also want to diagnose early cancer in their relatives.
Sounds like a very important conversation to have with one's primary care physician as soon as sort of there is concern about it, no matter whether they're a teenager or a young adult. Is it ever too early to talk about someone's risk of developing cancer based on genetics?
I don't think it's ever too early. I think the more knowledge we have, the more power we have in treating these patients. I think we just really have to educate what our patients and our physicians, what makes a high-risk breast cancer patient. So it really comes down to, and there's a list on our guidelines, but does one have a high-risk family history? For instance, do they have multiple family members being diagnosed with various cancers at an earlier age? Are they of Jewish ancestry, because they also have a higher risk of having, harboring these mutations? Do they have a family member with male breast cancer or triple-negative breast cancer? Some of these more aggressive types of cancers, because if they have that family history, they are at a higher risk of obtaining that mutation. So it's important just to identify the individuals and get the testing done.
And you talked about men. We're going to talk about that, because obviously breast cancer, a lot of people, I think, not a lot, some associate it with women, but it is also a disease that men can get. Talk about how male breast cancer differs from female breast cancer.
Yeah, no, that's a great point, and I think it's important just to highlight that, because like you had said, the majority of the population assumes that females are, the main individuals that obtain breast cancer, but that's not always the case. Yes, it's more common in females. Approximately 1 in 8 individuals, 1 in 8 females develop breast cancer in their lifetime, which is pretty significant.
Yeah.
But in males, it can also occur. Obviously not at that frequency, but it is its own entity that we have to be able to identify. So for our male breast cancer patients, it is important to let them know that they should feel comfortable talking about their breast to their family physicians. If they palpate perhaps, breast fullness or a breast mass, maybe enlarged lymph node, breast pain, that is not normal. They need to seek further evaluation to obtain imaging, biopsies, just like our female patients, so we can really get to the diagnosis and offer them treatment.
Talk a little bit more about your philosophy on patient care, because you're right. You're meeting these women at a very vulnerable, men too, at a very vulnerable time in their lives. What sort of tips or strategies do you carry with you when you walk into that room to
Sure.
have those conversations? Because they can be tough conversations.
They can be very tough, actually. So I think my philosophy is on day one, when I meet a breast cancer patient, I have to really start from scratch, because I have to understand that even if I'm the third physician that they've met, perhaps the first time that they met the physician and they heard the C word, the cancer word, the majority of the time, the information goes in one ear and out through the other. This is, they see their world, turn upside down. So when I first meet my patients, I make sure I have adequate time to sit with them first to see how they're doing, to understand, what do they understand about their current diagnosis and what they think treatment might look like. What are their expectations? What do they want to see happen? Because I think, when I first meet a patient, I just really want to not only understand them and their disease, but I want to also educate them, because I think, it says a lot for a patient who understands their disease and their treatment options, because it allows them to become, a great advocate for themselves and take a role on their care. So I think, day one, understanding what they know, educating them so they can, take a hand on their care, and then really letting them know that I'm here for the long journey.
Okay. Well, Dr. Ciuro, I appreciate you taking the time today to sit down with us, both you and Dr. Arnold. It has been wonderful to talk with both of you about breast cancer, and I look forward to speaking with you all in the future about other breast cancer related topics.
I look forward to that. Thank you so much for having me.
Absolutely. You're always welcome back.
Thank you.
And remember that you can watch this podcast, A Cancer Conversation, on the Georgia Cancer Center YouTube channel. Just go to YouTube and search Georgia Cancer Center. You'll also find us on some of your favorite podcast apps. So just search A Cancer Conversation or Georgia Cancer Center, and we'll see you next time.